Welcome. Let's talk about the medical management of mucus plugs. It's not uncommon in a hospital setting to have a patient develop atelectasis uh, due to a mucus plug. Now consider the following steps in asymptomatic patients. Asymptomatic patients with minimal symptoms, no significant desaturation, with some labored breathing but not excessive to the point of using accessory muscles. I would not advise patients who have significant O2 desaturation, highly increased respiratory rate for this method. Now consider the following. First of all, stop anticholinergic medications. Anticholinergic medications tend to thicken secretions and make it a bit more difficult for the patient to mobilize these secretions. Anticholinergic such as Robenol, or as you would know as glycopyrrolate, atropine, or ipratropium as well. So that's why stop the ipratropium and duoneps would be the first step that you want to do. The other thing to do is also stop the patient from being diuresed. If the patient is being actively diuresed, the loss of fluid may actually thicken some of the secretions. The next thing you want to do as well is to stop the patient from taking antitussives and even any sedatives. Sedatives and analgesics as well will weaken the patient's cough reflex. So I suggest stopping those. What you should do next is to encourage the use of the incentive spirometer. So incentive spirometry is really important, especially in some of these patients, but you need to motivate them. So have them taught by the respiratory technician or even the nurse. Show them how to use it every 1 to 2 hours with about 5 to 10 breaths each time. Now try to make it into a game so that the patients challenge themselves and self-motivating. The next thing to do as well is to have the patient sit up in bed. Now sit up at 45 degrees. Now even if it means bringing a protracted bedside, it's really important for the patient to be up and sitting up as much as possible to give you enough lung volume so that they can create a large enough force when they do cough. When they do go to sleep and if the patient needs to be lowered down, try to keep it at least 35-degree angle. If a patient's able to sit in a chair, that should be encouraged, or even encourage ambulation if that's possible for the patient. When lying in bed, have the area of the mucus plug elevated. So this gives enough chance for gravity to work by unplugging the mucus plug. So the side of the mucus plug, elevate that if possible. Use a wedge pillow, as that is more effective than just stuffing a pillow under the patient, which tends to flatten out. If the patient has copious amount of secretions, the other thing to use is a flutter valve. A flutter valve, or what is also known as an a cappella device, is helpful to mobilize secretions, especially thick secretions. A lot of the data that we have is from cystic fibrotic patients or even patients with bronchiectasis with non-cystic fibrosis. And these secretions may increase. You may be able to mobilize them more effectively, especially if the patient has difficulty coughing up the secretions. The next thing to do is to consider using albuterol and the nebulized albuterol with or without mucomist or N-acetylcysteine. But I've had more personal experience using bicarbonate, and this bicarbonate can be taken from the bicarbonate ampule that's frequently used at bedside, or you have your local pharmacist mix that up for you. The other option is you may want to consider a hypertonic saline. Now, hypertonic saline has been frequently used in cystic fibrosis patients as well. So my experience with that is specifically in those patient populations, but the theory behind it should also be applicable to other patients with thick secretions. What you want to consider doing, especially in patients if you're going to use nebulized saline or even nebulized bicarb for that matter, is to go ahead and give them the albuterol nebulizer followed by the bicarbonate mucomist or hypertonic saline. Now it's important immediately after that, which is equally important than nebulizer, is actually to perform manual chest percussions. Now it has to be manual chest percussions because that will be the most effective way to deliver the percussions to the areas required. The vibratory vests and the vibrating beds and so on may be a better spectacle, but nothing works better than manual chest percussions by the respiratory technician, especially in the area where the mucus plug is. So if the patients had that side elevated and they've got the nebulized albuterol followed by whatever nebulizer you want to use, go ahead and make sure that they do manual chest percussion for 5 to 10 minutes in that area and encourage a cough reflex. If a patient has a poor cough reflex, consider nasotracheal or even orotracheal suctioning to stimulate a cough. If that doesn't work, consider non-invasive ventilation. Now, non-invasive ventilation would include CPAP, BiPAP, or even high flow or bilevel, or even high flow oxygen, which tends to have a PEEP effect. And what this does is it tends to use collateral airways through the pores of Kohn and the canals of Lambert to open up this plugged up airways, and try to increase the PEEP if possible, as tolerant for that patient when using this method. Now, if all else fails, a bronchoscopy may be called for. The other option is have your local pulmonologist as well have a look at the patient. Thank you.